Coalition, RTI International, as well as ChangeLab Solutions and others. And so this is a part of our efforts to support decision makers using opioid settlement funds. So we're excited for you to join us today, and thank you. Today's webinar is brought to you through a partnership again with Big Cities Health Coalition, a forum for leaders of the largest metropolitan health departments to promote health and safety, as well as our partners at Research Triangle International, who you'll hear more about shortly, and who you'll be hearing from their team throughout today's webinar. Just a couple of reminders. You just heard we are recording today's session, and we'll make the slides and recording presentation available to you afterwards. Additionally, we hope that today will provide an interactive experience, so we encourage you to use the chat and Q&A function throughout the presentation. Also, please feel free to continue to share your name, organization, and where you're joining from in the chat. This project is supported by a cooperative agreement from CDC, awarded to Big Cities Health Coalition. Its contents are solely the responsibility of the authors and do not necessarily represent the official views of the Centers for Disease Control and Prevention or the Department of Health and Human Services. Through this webinar today, we hope to understand the opioid settlement funding landscape, including settlement plans, priorities, challenges, and opportunities. We also hope to continue providing technical assistance and capacity building opportunities to decision makers navigating opioid settlement funding. Next slide, please. We hope to build an understanding of strategies that span the continuum of opioid and substance misuse. And we also hope to continue promoting resources and the evidence around addressing opioid misuse and substance misuse. Next slide. To guide collective action in taking a comprehensive public health approach, Prevention Institute developed and proposes a set of 6 core guiding principles for decision makers to consider as they continue to address the opioid epidemic. We worked together with partners last year to consider what a public health and prevention lens to addressing the epidemic could look like, and came up with these 7 principles. These guidelines were developed to support investments in opioid settlement dollars and primary prevention strategies that create healthy community conditions and prevention, and to promote primary prevention strategies. But by no means are they meant to be prescriptive or exhaustive, and each community should give consideration to their individual context and experiences. The first principle, comprehensive investment across the prevention continuum. This includes considering balanced investments in primary, secondary, and tertiary prevention strategies to address immediate needs and root drivers of the opioid epidemic. Second, engaging in a multi-sector approach. We believe that it's critically important to convene stakeholders from traditional and non-traditional sectors to address the root drivers of substance misuse and to share effective practices and innovations. Stigma. We all know that it's critically important to actively counter stigma and understand how stigma permeates public understanding of substance misuse and opioid misuse, and invest in person-first, evidence-based response strategies to addressing stigma. We also believe it's important to implement approaches and solutions for those most impacted by opioid and substance misuse. And this means bringing and embedding a health equity lens to addressing the epidemic. This includes and should include an acknowledgement of how structural and systemic issues have created past and present inequities that may lead to substance misuse, and investments in building community trust, relationships, power, and voice for those most impacted. weaving together multiple forms of evidence. For us, what this means is leveraging best available research, which is critically important when looking at evidence-based strategies, but also considering contextual and experiential evidence when designing and implementing opioid response strategies. Building public accountability into spending plans. And that means ensuring that settlement fund decision-making processes center community-driven solutions, are transparent, and are also open to and engaging the public in decision-making and in understanding what modifications may need to be made throughout opioid settlement investing. And this takes us to today's topic for today's webinar, which is ensuring sustainable investment. This means considering opportunities to blend or braid settlement funding with other funding streams, and also conducting strategic planning processes that identify long-term vision for local opioid response. Historically, we know evidence-based interventions in public health have lacked reliable, sustained funding. So it's important to determine not only the best short-term use of the dollars, but also to identify early what the longer-term vision is for your local opioid response. To get us deeper into today's conversation, I'd like to welcome Dr. Derek Brown from Research Triangle International. And at the end of the webinar, or maybe now, we'll be sharing links for you to get the full set of principles and also a document that we wrote that explains more and provides really strong examples of where we see the 7 principles being implemented around the country. Without further ado, welcome Dr. Derek Brown.
Thank you very much, Dana. And hello, everyone. As Dana said, I'm Dr. Derek Brown with the Substance Use Prevention, Evaluation, and Research Program at RTI International. We're happy that you've chosen to join us for this webinar, and we're pleased to have the opportunity to discuss and share with you some considerations for sustainability planning and the impact it can have on prevention programs, strategies, and initiatives supported through opioid settlement funding. Next slide, please. More importantly, we hope this discussion will help you think about what sustainability means within your local context and how you can move forward in sustaining your efforts through ongoing changes in the federal funding landscape. We also hope to spark questions and ideas around sustainability planning based on your own experiences. Although we have set aside a few minutes for questions and answers later in this session, we invite you to type any questions or comments you may have into the Q&A field at any time throughout this session using the Q&A button at the bottom of your Zoom toolbar. Next slide. In addition to our partners at Prevention Institute and Big Cities Health Coalition, I'm very fortunate to lead and work with an enthusiastic, well-versed team of colleagues at RTI to bring this webinar to fruition. They include Ms. Fikir Wanda-Magenu, Dr. Barrett Montgomery, and Dr. Philip Graham, all of whom you will hear from later in this session. Next slide. So with that, I'm going to turn it over to Barrett to get us started. Barrett.
Thanks so much, Derek. Hi, everybody. My name is Barrett Montgomery. I'm a research scientist here at Research Triangle Institute, and I've been working with Derek, Fikir, and Philip, and others on the Opioid Settlement Fund initiatives for a while now. Prior to joining RTI, I worked in a community-based research setting where I became interested in the concept of sustainability. So to begin this webinar, I really wanted to begin where we always do in science, with reviewing the state of the evidence, and in this case, regarding the major barriers to making community evidence-based practices sustainable. So the findings I'll be discussing come primarily from these 3 papers from researchers at the National Opinion Research Center in Chicago, the Washington University in St. Louis, and a team I worked with at Michigan State University in Flint, Michigan. You can find all of these citations and links to the full papers in the sources handout that was distributed earlier. Next slide, please. So the primary reason that most evidence-based programs are not sustained is due to a lack of funding. Many community-based prevention programs struggle with inadequate funding and making it difficult to hire and retain staff, provide adequate training, and purchase necessary resources. The second most common reason is that our challenges with program implementation. One issue is this tension between adaptation and fidelity. While some research-based programs might not be suitable for all communities, adapting them can compromise their effectiveness and require significant expertise in research and program development. So finding the right balance can be difficult to sustain. Other factors include difficulties integrating the programs or initiatives into the community, pressure to see quick results that can lead to rushed implementation, and then a lack of sustainability, a lack of awareness of the benefits of your program or evidence-based programs more broadly can also be an issue. The third most common includes contextual factors in the community, making sure that the intervention materials are sensitive and culturally appropriate. That's something that's within the interventionist control. However, the evidence-based programs are typically built on evidence from large group averages, so not all individuals are going to get the same level of benefit. And very few evidence-based programs can address the core and complex social determinants of health in the community, such as poverty, discrimination, and the lack of access to resources. Next slide, please. So last year, with the help of Prevention Institute, we produced a report all about how to effectively monitor and evaluate the use of opioid settlement funds, which included some important strategies to overcome these barriers to sustainability. Next slide, please. This webinar and the written guide was designed with multiple levels of decision makers in mind, from the larger state entities down to the local level where the work is really happening. So our guide really emphasizes the importance of monitoring and evaluation to avoid repeating the past mistakes. For example, the tobacco settlement funds from the Master Settlement Agreement were often diverted to purposes unrelated to tobacco control. Above all, we strongly advocated that all the stakeholders prioritize sustainability planning from the very beginning. Our focus today on sustainability is an extension of this prior work, and we covered many elements of monitoring and evaluation as a means to support sustainability of initiatives. And we'll cover two of those topics today. Next slide, please. Regularly gathering and incorporating feedback is one of the best ways to overcome implementation barriers I brought up earlier. The feedback combined with outcome information will allow you to navigate that tricky balance of adaptation and fidelity, which will then help foster a sense of community ownership and integration. Starting sustainability planning early also establishes a long-term perspective that helps resist the pressure for quick and short-term results. Next slide, please. And sharing materials throughout the community is another vital step towards sustainability. This dissemination process builds community ownership and helps integrate programs into existing communities. We've included some key considerations here for how the information should be conveyed and also how to reach the right audiences. You can find more information in the guide. Again, there's a link to it in the sources handout. But I want to stress here also that when the information is accessible and in the hands of the right people at the right time, it can really help obtain or your chances of obtaining new funding. Next slide, please. So let's talk more about funding, since after all, that was the #1 barrier to long-term sustainability of these practices. We'll be using these terms pretty often, so let's be clear about what they mean. Braided and blended funding both refer to methods of pooling funds from various sources to support the same initiative. The difference is that braided funding means you'll need to track and report on the contribution of each source individually, while in blended funding, there's no need for differentiated tracking. So the difference in the approach is primarily funder-driven. The outcome will really be the same, but reporting on the funds is what's different. Next slide, please. All right. So these tables cover different sources of funding that can be braided or blended with your opioid settlement funds, with some relevant or interesting facts about them to get you thinking about how they might be used, or which ones are more appropriate than others for the programs and the populations that you serve. Please note that this information is all completely accurate as of very recently. However, we know that this landscape is rapidly changing. I was listening to news just this morning to try to update my thinking on this. So we'll discuss some caveats here and focus on changes in the landscape in the next section also. But this first table here is on insurance sources. So of course, Medicaid is a very common, probably the most common source of blended and braided funding for substance use disorder prevention and treatment. And it can be billed for certain substance use disorder treatments and prevention services for qualified low-income and disabled people. And then there's 1115 demonstration waivers that allow states to waive certain provisions of the Medicaid law and receive additional flexibility to design and improve their programs. Medicare is another source that covers early intervention, outpatient, and inpatient treatment, but it does lack coverage for more intermediate levels of care. And except for opioid treatment programs, Medicare does not cover community-based treatment facilities that are not affiliated with a hospital system. So keep in mind that although no funding cuts have yet been made official to Medicaid or Medicare, this obviously remains a very significant possibility, and it's currently being debated. Last week, the House Energy and Commerce Committee, the committee with jurisdiction over Medicaid, approved some large cuts to Medicaid. And these cuts aren't, at least as they're currently being discussed, are not financial in nature. They're more around the eligibility requirements for Medicaid. So it's more around the population that can be served rather than funding. But given all of this, commercial insurance might therefore actually be a safer source of sustainable funding if it is possible for your population, though benefits definitely vary by plan. Next slide, please. This second table focuses on funding from the Substance Abuse and Mental Health Services Administration, or SAMHSA. So block grants like the Substance Abuse Prevention and Treatment Block Grant, or SUPTRs, and the Mental Health Block Grant, or MHBG funds, are intended to help with the planning, implementation, and evaluation of specific activities or programs. SUPTRs funds must be the funding of last resort for substance use disorder treatment services, and substance use disorder treatment providers are required to exhaust all efforts to collect payment for services from eligible Medicaid or private insurance or any third-party program before billing SUPTRs for services. So that's an important caveat to keep in mind for that source of funding. And again, it's good to keep in mind here the level of funding cuts that are currently being discussed at SAMHSA. So the recent skinny budget proposal for fiscal year 2026 seeks to cut just about $1.07 billion from the agency. Next slide, please. Other block grants, such as the Maternal and Child Health Block Grant, which is administered by the Health Resources and Services Administration, or the Community Services Block Grant that's administered by the Administration for Children and Families, have also been used by states to support certain substance use disorder services. Unobligated funds from the American Rescue Plan Act were, of course, recently clawed back, so these really should not be considered as an option for future project funding. Some of that funding that has already gone out is still being used and going through, but we don't think it's a viable source for future funding as of now. In some states, the revenue for substance use disorder prevention, intervention, and treatment is also generated through fees or taxes imposed on alcohol or cannabis where legal. So that's something important to keep in mind if you're in one of those states. And another great source is private foundations at both the national and local levels that can provide funding for treatment and prevention programs as well. All right, thank you. Next slide. Okay, so let's talk about the elephant in the room. There are some massive changes in the current funding landscape that present challenges for sustainability, some of which we have already discussed, but let's dig a bit deeper here. Recent cuts to the Health and Human Services budget and various organizations within it, including the CDC and SAMHSA, are really shaking things up. In March, there was an $11 billion cut from the Coronavirus Aid, Relief, and Economic Security Act, as well as the American Rescue Plan Act. There were reductions in force of nearly 20% to the CDC, the NIH, and to the FDA. Some of these folks likely supported state and local departments in crisis management and day-to-day activities. So an additional reductions to some of these departments are already being openly discussed. The block grants that many local departments rely on have particularly been impacted. Next slide, please. So while we don't have a crystal ball and things could always change, right now we think that the silver lining here is that we really don't see a way that these opioid settlement funds can be cut or reduced in the same way that some of the federal funding has been affected. Unfortunately, though, this also puts a big target on the opioid settlement funds as a potential stopgap solution to fund those programs that lost funding in the federal clawbacks. If you attended our webinar last year, you'll recall this is exactly the type of action that the proponents of the opioid settlement funds were really trying to protect against because of the history of those missed opportunities from the tobacco master settlement agreement that I talked about earlier. In the 90s, that money was going to all types of purposes that had really nothing to do with tobacco smoking reductions or prevention, but instead it was being used in many cases to fill out state budget deficits. And unfortunately, this is kind of already happening in some states. So be sure to pay attention to how this might affect the availability of opioid settlement funds in your area. This gives us even more of a reason to be thinking about sustainability strategies and how to plan for blended or braided funding now. Next slide, please. The good news is that this unique flexibility of the opioid settlement funds provides a vehicle for upfront investments that can really help you prepare for identifying braided or blended funding opportunities and transitioning to other sustainable funding models. Next slide, please. And while we don't want to be overly prescriptive here, we think that generally most organizations can consider how to use opioid settlement funds to support early investments into capacity building, data systems, and other infrastructure that will prepare the organization for longer-term success. While programs and services are vital, investing in internal capacity is what ensures these initiatives survive beyond the initial settlement funding and can be funded by other sources to further stretch the limited opioid settlement funding dollars. And this slide highlights 4 strategic investment areas that can create some lasting infrastructure. So for the workforce development, you could invest in specialized sustainability roles, such as dedicated grant writers or program evaluators that will support your long-term success. Of course, you'll also want to invest in training the staff on evidence-based practices and ways to build institutional knowledge that can remain even as personnel change. For data and evaluation systems, I think of these not so much as just administrative tools, but as sustainability assets that can demonstrate the program value to future funders. Programs that can show concrete outcomes are more likely to secure ongoing funding from other sources. For financial planning, staff trained in diverse funding acquisition can help to identify and secure sources beyond the settlement funds. The most sustainable programs really start financial diversification planning from day one, so not just when the settlement fundings are running low. And finally, the cross-system integration is a way to eliminate redundancies and create cost efficiencies that extend program lifespans. As I stated in the braided and blended funding slide, there is really no single funding source that covers all the types of services that are needed to help people prevent or recover from opioid use disorders. Integrated care models address multiple dimensions of opioid use disorders and can also access multiple funding streams across healthcare and public safety, creating more financial resilience. Next slide, please. There's a really excellent example from the Karlsruhe system, as reported by the National Academy for State Health Policy, that discussed how 11 states, including Alabama, Michigan, Delaware, Virginia, and Nevada, used the opioid settlement funds for upfront investments into prison reentry and began braiding funding with the Medicaid 1115 demonstration waivers. You can find the full link to this story in our source handout to learn more. Next slide, please. All right. To wrap things up here, thinking about our communities and partnerships, I wanted to highlight that in the current climate, there's really been a reduced pattern of support for programs that help specific communities. So many federal agencies were really racing to remove terms like diversity, equity, and inclusion from their documentation and their websites. And so if you have terminology like this in your program title or description, you might want to consider alternative language if you're trying to get programs funded by federal sources. But I want to end on a positive note about leveraging your social networks and that communicating with your policy and decision makers is really more important than ever. There was an excellent workshop hosted by the National Academies of Science back in 2017, all about implementing evidence-based prevention by communities that discussed the role of social networks in sustaining evidence-based programs in schools. And again, you can find the full sources in the sources handout. But the speakers really highlighted the importance of key informants as a source of information and advice because they got new information into a setting and they encouraged other people to adopt and to use an intervention. So for example, Mark Atkins, who's a longtime professor at the University of Illinois in Chicago and a leader in school-based evidence-based programs, really spent time identifying the teachers who were influential with other teachers and asking them what parts of the programs were interesting and important. These influential teachers are then in a position to share that information, leading to a good reputation for the program, which improves sustainability. I think this story really highlights the importance of getting the right information into the hands of the right people at the right time, which is something we all need to be thinking about a little bit more about right now. Next slide, please. All right, so I'll now turn it over to my colleague, Fikar Wandimagenu, to place the spotlight on a few case studies in sustainability of opioid settlement-funded efforts across the country. Thanks.
Thank you, Barrett. Hello, everyone. My name is Fikar, and like Barrett said, I'll be taking us through some real-life examples on sustainability planning that we were able to find in different states and local communities. So right now, there is a lack of accessible and detailed examples of opioid settlement funding sustainability planning. However, we'll be going through some of the encouraging information that we were able to find within annual reports, toolkits, so on and so forth. So starting with the state of North Carolina, we find that the North Carolina Association of County Commissioners is supporting local governments in using opioid settlement funds by providing resources in strategic action planning, collaborations of connections, and program implementation support. So one of their resources is the Collaborative Strategic Planning Toolkit that defines collaborative strategic planning as a process used to create a vision and a defined plan for preventing opioid overdose deaths and to collectively make our communities safer and healthier. So this toolkit can be used either as a step-by-step walkthrough of the entire collaborative strategic planning process or as a resource to consult for specific planning activities. As of January 2025, we see that 56 local governments have reported plans to use their funds on collaborative strategic planning. Next slide, please. Okay, so we have Exhibit C under the North Carolina Memorandum of Agreement for Opioid Settlement Funds, which is basically where this collaborative planning process that we just mentioned is laid out. So this planning process would be required if the funds are to be used for strategies beyond the top priority list. It has 14 steps, A through N, which is what the visual is showing, that all emphasize different aspects of collaboration, data-driven decision-making, and the setting of clear goals. However, for the purposes of this webinar, we will focus on step K that offers guidance on sustainability through the alignment of strategies by finding opportunities to braid opioid settlement funds with other funding streams, developing regional solutions, and forming strategic partnerships, as well as pursuing other creative solutions. Next slide, please. So step K lists several sustainability planning specific questions to think through. The first set of questions encourage us to look for opportunities to leverage braiding opioid settlement funds with other funding streams. So this can look like identifying funding streams that complement each other and support similar opioid-related or public health goals. Maybe even identifying funding sources that desire focus on the same population, right? This can also look like spotting where settlement funds offer more flexibility, where you could use them to do things that other funding sources can't, while also recognizing the flip side where settlement funds have limitations, so that you could find other sources to fund those parts of your strategies. And lastly, identifying grant opportunities that require matching funds and considering the use of the settlement funds to meet that requirement to unlock more money. Next slide, please. So the next set of questions are helping us think about sharing resources, staff, or programs across counties or regions, jurisdictions. And this is where you could identify existing networks or partnerships to tap into like existing regional health alliances or councils of government, so that you don't have to build new collaborations from scratch, essentially. And this is done to position your goals and your strategies as part of an existing movement or plan in your region, to allow you to share infrastructure, data systems, or workforce pipelines, which may help attract more support and funding with larger public health and economic goals. Next slide, thank you. And the last set of questions in there consider implementation by identifying local stakeholders that are doing similar work in addressing root causes and partnering with them to co-develop shared sustainability plans, shared services. So yeah, we'll take some time, a few slides down, to look at some examples of amazing partnerships, but this really helpful toolkit can be accessed in the sources handout that will be received after the webinar. Next slide. Okay, so we are now moving on to New York. So we have the New York State Office of Addiction Services and Supports. That is the lead agency responsible for oversight of the Opioid Settlement Fund. And then we have the Opioid Settlement Fund Advisory Board that provides recommendations at the state level for funding allocations. So the most recent, the 2024 annual report emphasized the need to sustain programs that serve co-occurring disorders and special populations. However, the board also expressed concern over the lack of integration between their work and the state agency's strategic plans, sharing that it is restricting their ability to recommend funding for programs and services that will then be sustained by the state after settlement dollars have been exhausted. So they did provide some recommendations, one of the main ones being to develop a New York State opioid settlement strategic plan by engaging an external consulting firm to create a sustainability aligned plan, and aligning this plan with the strategic objectives of the Office of Addiction Services and Supports, Office of Mental Health, and the Department of Health as well, and really emphasizing long-term continuity through cross-agency coordination and best practice replication at the county and regional levels as well. We thought that this is a great example of the acknowledgement of the need for discussions and considerations around sustainability as early as possible. Next slide. Okay, so that was a state level example in New York and North Carolina. We were also able to find 18-month project proposed by an organization called IPRO, seeking to increase the number of patients screened for opioid use disorders and treated with buprenorphine by practitioners within primary care practices in Cortland County, New York. So this proposal is aiming to use opioid settlement funds to develop a workforce through the utilization of a dual train the trainer model, basically seeking to train community health workers for them to then become peer leaders for the chronic pain self-management and self-management programs. Also leveraging existing personnel within local organizations to do this. And then once they're all trained, they can train other trainers. They can train others, and then that system would keep going. Next slide, please. Thank you. So the proposal is also aiming to strengthen systems and infrastructure by aligning the work of healthcare providers and community-based organizations via an intentional electronic health records EHR integration process. They also offer technical assistance throughout the project and after the project ends. So they like to ensure that continual feedback is also received and used through consistent documentation of information. And lastly, really making sure to engage stakeholders throughout the entire process to inform sustainable decisions. Next slide. Thank you. And lastly, really focusing on sustaining the project's progress after those initial 18 months by providing licensing opportunities, looking for other funding sources early on, and also encouraging a strongly connected ecosystem for everyone involved through a collaborative online forum. Next slide. Thank you. So IPRO's proposal was a great segue into really what county and city level efforts can look like. This slide is here to allow us a very brief moment to acknowledge that about 50% of all opioid settlement funds is going directly to states, and the rest is being received by counties and cities, counties being the ones getting the larger portion. Next slide. Thank you. Fortunately, we were able to identify some examples where counties and cities are coming to work together. So first up are Clinton County and the city of Frankfurt in the state of Indiana, where they've created a joint opioid settlement funding committee, including elected officials, first responders, and various other stakeholders. So this is very exciting because we see how they're allocating their funding based on the joint community health needs assessment that they conducted in both of the areas. And I can give you a quick moment to read an encouraging quote from the committee chair and executive director of Healthy Communities of Clinton County. Next slide, please. I hope that was enough time. We also have New Hanover County and the city of Wilmington in North Carolina. Very similar case where they formed a joint subcommittee on opioid settlement proceeds. They have established 3 main areas of focus that are listed on the slide, and they make their recommendations accordingly. And then the city council and the board of commissioners review and approve the recommendations that are made. This is also an example similar to what they're doing in Indiana. There's also another quote that I'll give you a second to read. Next slide. Thank you. Yeah, and last but definitely not least, we have Arkansas with the Arkansas Opioid Recovery Partnership that has united local government representatives to allow the pooling of their resources. So this partnership evaluates proposals, makes recommendations, and seeks to empower evidence-based programs and strategies, the utilization of evidence-based programs and strategies. And we've also highlighted their principle number 2 of the 9 principles that they also list on their website that again touches on the key sustainability focus of supplementing and expanding existing efforts and funding, and avoiding any duplication to ensure resource maximization. So these are all the examples that we were able to find. Again, all of them will be in the source handout that you all receive after the webinar. So thank you so much. Next slide.
Well, thank you very much, Barrett and Feker, for that descriptive and very timely overview. We do have a quick poll question that we'd like to get you all to respond to. Claudia, do you have that question queued up? while we're waiting for that poll question to come up, I again invite folks to um, post any questions they have in the Q&A at the bottom of your screen. You can also unmute yourselves and verbalize your questions or make comments on the material that's been presented so far. And there is our poll question. It's an open-ended question, but we want to know, what is one sustainability strategy from these case studies that were just presented, which resonates with you in your local context? Hopefully you saw some relevant pieces in the presentation, or something similar that you all might be using in your sustainability planning and implementation. And if you have multiple sustainability strategies that resonate, feel free to put those in. We will not limit you in your answers. All right. But while we're doing that, we just want to take a couple of questions at this point. We have two questions in our Q&A. The first one from Susan. She says, are CHWs, community health workers, as a profession reimbursable in the state of New York through Medicaid? Must the beneficiary be in a waiver program? I'll let Feker jump in, but I do not know the answer to the first part of that question. I don't know if community health workers as a profession are reimbursable in New York State, but it does seem that that labor category, that labor profession is becoming more common, slowly, but surely more common for reimbursement of community health workers, certainly for providing services such as substance abuse, substance use prevention and treatment services. But Feker, do you have more information on that from the New York example?
I do not have more information on that, unfortunately. However, I could definitely look more into it and answer it.
I think Barrett
Type an answer. Yeah,
Barrett,
maybe.
let you jump in here.
Sure, yeah. It might depend on the specific context. Most importantly, it probably depends on the type of service that they're providing and who the beneficiary is. But generally, yes, it's definitely possible.
Okay, thank you. And then our second question, what is the cost benefit of investing in a consulting firm to build a sustainability plan when funds are limited? Feker? You're muted, Feker.
Thank you. I wanted to quickly acknowledge that I believe there are also other people placing answers in the chat, so that might be relevant information. Yeah, but for the second question about investing in a consulting firm, at least specifically for the state of New York, when they made that recommendation, they provided a very brief note that they're seeking to do this via pro bono or alternative funding. So really trying to find innovative ways to fund that.
Great. And of course, there could be other efficiencies in bringing in a consulting firm to help with sustainability planning, rather than sort of farming that out to different entities, the local or state level. Certainly, you have firms with lots of expertise in doing that, in data gathering, data sharing, convening groups, doing the whole negotiation sort of process among groups to hammer out a good sustainability plan. So there are certainly benefits, but then you have other costs, other indirect costs that come along with that. It's something that will have to be adjudicated, I guess, among you and your team when deciding on whether to engage a consulting firm. We have a few other comments that I see in chat. Some folks appear to still be struggling to help decision makers see the value in demand reduction as opposed to just harm reduction. That's certainly true, I think, across several communities. Someone also suggests checking Medicaid state plans to learn about various reimbursable services. So I think that gets back to the first question as to whether community health workers specifically can be reimbursed. Also, there's potential for billing through Medicaid with 1115 waivers. That's another option. Thank you all very much for those suggestions. Other questions, comments at this point? All right, well, we're not done yet. That was just the first portion of this webinar, but we have more in store. We really appreciate these questions and comments. But now we're going to transition to the second portion of this session. We're very excited to welcome two guests today, both of whom have a wealth of experience in administering and leading opioid abatement funds and partnering with various entities to ensure the successful implementation of efforts to address the negative effects of the opioid crisis on their communities. Joining us is Dr. Orlando Barker, who serves as the Director of the Office of Opioid Abatement at the District of Columbia Department of Behavioral Health, where he leads strategic efforts to combat the opioid crisis across the district. With more than a decade of experience in substance use prevention and behavioral health, he's committed to building equitable, community-driven systems of care. Previously, Dr. Barker served as the State Opioid Response Project Coordinator, managing grant initiatives, providing technical assistance, and coordinating key stakeholder groups. He's also led the Partnerships for Success program in Wards 7 and 8 through the DC Prevention Center. And he served as chair of the DC Recovery Advisory Council, which supported the development of a recovery-oriented system of care for mental health and substance use services across the city. Welcome, Dr. Barker.
Thank you.
Also joining us is Mr. Kirk Lane, who serves as the director of the Arkansas Opioid Recovery Partnership, an organization formed by the Arkansas Association of Counties and the Arkansas Municipal League to administer opioid abatement funds derived from the opioid settlement, awarded to the various cities and counties of Arkansas. Before this, he served as the Arkansas State Drug Director. Mr. Lane also served over 3 decades in law enforcement with the Pulaski County Sheriff's Office and as the Chief of Police for the city of Benton, Arkansas. Welcome to you, Mr. Lane.
Thank you.
So, gentlemen, we would like for both of you to start by giving us a brief overview of the mission and priorities of your state or district's Opioid Abatement Council. Perhaps describe one program, strategy, or initiative on which opioid settlement dollars are being used, and tell us what sustainability means in your local context. So I think based on the last slide that Feker shared, the Arkansas example, I think that's a nice segue to start with you, Kirk. Since you are in Arkansas, we'll let you start with that brief overview and description.
And thank you for having me today. I'll start by saying that our concept was a little bit different than most states. Our attorneys that we worked for actually pursued litigation from a city, county, and state aspect, and got a settlement. And that's 1/3 for the cities, 1/3 for the counties, 1/3 for the state. The cities and the counties came together and formulated the Arkansas Opioid Recovery Partnership and pooled their money together, and then hired myself and my deputy director away from the state, for lack of a better term, to administer these funds and get them out the door. So that was the start of it. That started in 2022, and we have had to build a system to get that money out there. And we did a proposal type concept along with the impaneling and advisory board to help us with that, selecting people from all over the state with various demographics that we felt and expertise that would help us make good decisions on the dollars. To date, we have had about 466 proposals asking for a total of $384 million money we don't have. But we've been able to approve 194 of them for about $31 million that we put out to date. And we look for sustainability in those programs. Honestly, we don't always get it. We're trying to focus our dollars on expanding what the state is doing and coming from the state. We kind of know where those um, issues are and where they need to be. So we try to expand and work alongside our state partners to expand those programs in the state.
Thank you very much for that brief overview. Orlando, hear from you now.
Hey, thank you. And I did have a few brief slides to share.
Sure. Screen share here.
All right. This over here. Okay, so again, thank you for having me here. I will sort of move through these a little bit faster because I know a lot of to get more to the meat of the sustainability, but I did want to sort of present a background of how we started in DC. So the first thing to realize in DC, obviously we're a district, we're not a state. So we have a lot. It's a smaller entity, although we are working with 700 individuals, which, 700,000, I should say, um, citizens or residents in the District of Columbia, which is bigger than some states. But the point is that we essentially have one central sort of bureaucracy. We don't have counties, things of that nature. Um, and as far as the money, we started receiving settlement money back in 2021, but there was no infrastructure yet in order to spend this money. And so this money it started with the Opioid Litigation Proceeds Act of 2022, and with this was created the Office of Opioid Abatement, which I'm currently the director of, which is in the Department of Behavioral Health, which is agency responsible for behavioral health needs of district residents. And then there was the creation of the Opioid Abatement Advisory Commission, which is a 21 member body, which is separate from Department of Behavioral Health. It has uh, it has a number of individuals from within government, so government officials, as well as private individuals who make up this commission. And the private individuals are both appointed by the mayor and the council. And so the idea is that the Office of Opioid Abatement is responsible for managing the fund, grant making, procurement issues, whereas the commission sort of provides, guidance, advice. They make recommendations on particular areas of focus that we may want to focus on, etc. And they hold public meetings, and we put all this information, all the public meetings online. As far as the funding that we're projected to receive probably about $80 million over the next 18 years, or up until around 2041. And so far we have received about 28 million. Um, and like I said, last fiscal year, so no fiscal year 2024 was the first year we had spent any money because that was the first year that the office and the commission were established. The other thing I want to present in terms of understanding sustainability in DC with these funds, we have to look at Live Long DC. Live Long DC is it was the original strategic plan created by a number of government agencies, DC residents, that was adopted and is the sort of standard bearer for how we should address the opioid crisis. Um, that is, that is promoted by the mayor of the district. And so it's the underlying strategic framework for how we address the opioid crisis. Now, Live Long DC started before a bit before opioid money started coming in. This started officially in 2018, but I was part of the original group that came together and we started talking about this in 2017. But it was a series of different meetings, and then finally we created this Live Long DC strategy, and then you know, one of the biggest pots of funding that helped propel this forward was the state opioid response grant, SOAR grant, as was mentioned in a lot of in the presentation before. And so the SOAR grant was sort of the basis, but there were other sources of funding. There was CDC funding. There was other local money, the subtours, the substance use prevention, treatment, recovery services. That was also a small part of it, but SOAR was kind of the basis of it. I point all this out because Live Long DC is kind of giving us the framework for how we evaluate what works and what doesn't. As you see here, we're on 3.0. 1.0, we had a number of different areas that we focused on, particularly within the prevention, harm reduction, treatment, recovery spectrum. And, we also focus on criminal justice and workforce development. But as we went through those, what worked and what didn't work, we evaluated. And there have been changes over the years. So we've sort of looked at, what we want to continue funding, and we, went in that direction. And so that's how we've gotten to 3.0, because we've had subtle changes since, like I said, 2018 when this started. Um, Now, as far as just some of the initiatives that we are doing. This is by no means a comprehensive list. This is just, but these are some like big groups that we are focusing a lot of funding in. We have peer workforce development. This is a big one, and you saw before I mentioned in the Live Long DC, workforce development is very important. We are particularly focused on peer workforce development because one of the things we've been seeing over the years is that a number of our activities, there's the need, the very essential, important need for peers, peer support workers. Um, and what we've needed essentially is just having the training and the apprenticeship to make sure people who are receive their certifications or who are being trained, they get that experience. And then they also are in a position where they can actually make a career out of what they're doing. And so this has been something that's come up a number of times over the years. And so we really wanted to make sure we're putting some money into supporting that peer, workforce development. Some of the other things, improving overdose response infrastructure. This is sort of a big area. We have been funding an overdose response team with fire and emergency services, and this is basically a team that responds to people who've overdosed. Um, and they talk to these individuals like overdose and are not going to the hospital. So we've expanded this infrastructure, one starting at the hospital. So at the hospital, if people go to the hospital, they can get there's buprenorphine induction at the hospitals itself. But a lot of people don't go to the hospitals, they choose not to go. And so we have this team that goes out and engages these individuals. And now we have our support has allowed them to uh, induct, buprenorphine in the field, so they don't have to go to the hospital. They can start doing it in the field. So that's one of the new innovations we have. But also to expanding sort of the data infrastructure on looking at these overdoses so we can track them. So improving our data surveillance is another part of this area. And then last but not least, housing. There's always a need for housing, especially when we're talking about this population that's normally suffering. So we put a lot of funding into housing. That leads us all back into this idea of sustainability. What does that mean, and how are we doing it in DC? Well, I would say one of the biggest things from a sustainability, first of all, I mentioned the Live Long DC, and I've talked about these different things. But when opioid abatement funding started, there was a huge, I should say, desire for us to get this money out into the community. The community, a lot of community providers were very excited. They wanted to try their innovative ideas. So we had to sort of, we worked with the commission, we meaning the office, and DBH work with the commission to come out. What are some of the best ways we can put this money into the community? And the commission created they made these 14 recommendations on areas that we can fund. These are based on the data we showed them, the gaps that we were seeing in previous data. So they worked with us, they came up with these different ideas, and we put it out for different opportunities. And what we found is with community providers, the first thing we do is we ask all our community providers to give us a sustainability plan. What happens when this money is gone? Because, we've told them because um, the intermittent schedule that the money comes from this opioid abatement, we've informed them that, hey, look, this money here is not like it's not like SOAR. A lot of our community providers are used to the SOAR funds or other funds where they have 2 years or more to get these funds. But with opioid abatement so far, we've really focused on this is an injection. This is a one-time injection. We'll try to give you 12 months, but we can't promise you any more money after that because we don't know if we're going to get any more money and we don't know when the money's going to come. So we really focus on giving these injections of funding for people to sort of start their programs. But in that, we're asking them, how can you make this sustainable? What are the things you can do to continue this program once this funding is gone, or if it's not available next year? So that's the first thing. Also, too, we work with these community providers in achieving the credentials they'll need in order to allow them to bill for services. A lot of these, we talked about the peer workforce development. A lot of these programs, people have peers and are using peers to do a significant amount of work that they can bill for under the 1115 waiver. And so part of that is educating them on that and letting them know, like, getting them the support they need. Our office doesn't necessarily do it ourselves, but we have entities at DBH, at the overall agency, that do provide that information. We make sure we try to get them connected to that and get them the education they need and the training they need to be able to, bill for their services. Uh, and then of course, government agencies, we fund a lot of government agencies. The example that I gave with the overdose response is mainly funding through various uh, district agencies. Well, in those cases, the sustainability is a lot of it is um, looking at other sources of funding. So the reason why I really wanted to show you the Live Long DC and particularly talk about SOAR is because SOAR has sort of been the major opioid funding that we've had. The opioid abatement funding is just a small amount compared to, SOAR's around about $24 million a year at this point. So we're talking about a smaller amount of money, 80 million over 18 years. That's nowhere near in comparison. So that really has been the major source of funding that we've been able to get. Now, if something happens and SOAR no longer exists at some point, there are other sources of funding. There are, there are of course local. There are other sources of federal funding, et cetera. So one of the things with government agencies, they have a better ability, obviously, to seek those other sources of funding out. So yeah, so I mean that's mainly, I would say, the biggest ways that we try to um, encourage sustainability as much as we can. But we look at it in DC not as just a simple issue of the opioid abatement funding. We really kind of try to look at it holistically with all of our opioid-based funding and substance use-based funding as a whole. And that's why I wanted to bring up again that Live Long DC strategic approach, because that goes beyond the funding. It goes like, how do we look at this with all these different sources of funding? We have one district and we have these issues, but we're constantly working together. So that's how I wanted to make sure we show that in a very broad way.
Thank you.
All
Thank
right.
you very much, Orlando. That holistic approach is certainly one approach I'm sure folks are considering. Um, and we appreciate what you've shared. You sort of took us well down the line and answered a couple of questions, but we want to bring you both back in and dig a little deeper into your sustainability plans within the local context. So, Philip, I think you have a question for our panelists.
Yeah, the first question is going to be to Kirk. And so, as you just talked about earlier, you guys are doing things very differently in Arkansas. And while, so two questions I want you to answer, but as an evaluator, I'm going to start with the evaluation one. And so, from your perspective, how do you assess which initiatives are viable beyond the opioid settlement timeline? And then, what metrics or signals are you using to make those decisions? And once you've talked about that, then we'll circle back around, talk more about some of the approaches you are using with respect to sustainability.
Yeah, so I think what we look at each proposal that is brought to us individually, And one of the pieces in there and one of the questions we have in there is sustainability. So I think we kind of dig into that whole proposal because we realize that the opioid settlement money is, for lack of a better term, blood money. And we look for the heart of the proposal. Are people just wanting money to sustain, or are they really trying to make a difference in their community? And so we kind of dig into each one of those proposals to find out um, the answers to those questions and look at their history, look at what they've done, look at their background, we ask them for data about opioid abatement issues that they've had, either successful or non-successful. And then we look at their program overall and what they're doing. And we want to make sure that it's not replicating something that the state is doing in the same area so we can expand from them. So that's kind of part of it. We look at a lot of times we look at the length of their funding, what they're looking for. Is it 1 year, 2 year, 3 year? And then what their plan on sustainability is. We don't really have a cookie cutter answer to sustainability because programs vary and the needs in each community vary. So we kind of look at that and we get buy-in from the mayors and the county judges in those prospective counties where those proposals are coming forward. Is this something they want and something they can get behind in their community? So that weighs into our decision-making process.
Thank you very much, Kirk. Orlando, do you have anything to add to that response? Or
I guess I would need to hear the question again, only because it's very different. Like we have a very different experience. When I hear that answer, it's like we don't have, the different levels. So we're very unique. So Dr. Graham, was there?
Yeah, so if you could focus on how do you, in terms of evaluating what's working and what's not in your funding,
Okay.
so how do you assess which initiatives that are viable beyond this initial year? As I understand it, most funding is a 1 year at a time.
Yeah.
And so I don't know if you only do 1 year, but more importantly, how are you gauging or assessing what's viable and can be sustained beyond that initial funding?
Well, essentially, this is our first year. Like I said, we did start last year, but we started like late in the year. So a lot of the programs that we started late in the year, they continued into this year. So this is sort of our first year of understanding, like of evaluating what's going on and what's working. I would say the first thing is, are you meeting the basic numbers, that you said you'd be able to meet? So everyone at the beginning of their projects, they basically, well, I shouldn't say everyone, it depends on the project, but a number of the different projects did have these sort of tallies on, generally, how many individuals could they reach or provide services to. So we look at that. We also look at, again, Live Long DC is constantly sort of looking at everything because, we don't want to look at our opioid abatement funded projects in a silo, because a lot of the stuff we're funding is similar to what source funding. So we need to like kind of look at all these things together and see, what we're finding. If there's anything particularly, we have a lot of data, a new data dashboards. We're constantly Department of Health, DC Health, and DBH are constantly looking at these different sources of data that come from, data from overdose, data, fatal and non-fatal, where, the overdoses are happening across the district. And then, the amount of medication, what are the medications that people are using? So there's constantly like we're constantly observing these things over the year. And so after we sort of look at these things over each year, we're constantly looking to see and talking amongst each other, what is where are the gaps? Is there something we're missing? Is there something we're not missing? Is there an area we're doing really well in? We've seen the number of naloxone kits that have been dispersed has went up dramatically. So it's like, okay, we're seeing successes here. We're seeing that the overdoses are going down. Although, no, let me take it back. Fatal overdoses are going down, non-fatal overdoses are going up. at the same time, our, naloxone distribution numbers are going up. So we want to maintain the naloxone distribution kit. So maybe, we expand that program and how we, do that. So it's kind of like constantly looking at information. Like I said, this will be our first year of looking at what we've done now. And some of the, I think there are some areas where we might want to prioritize just based on knowing that, over the years, these are constant areas of like problem. Like, I would say housing has always been an issue when it comes to individuals in the substance use area. And, and trying to address the issues with people with substance use or OUD, making sure they have housing, at least temporary or where there's transitional recovery, these different types of housing. So I think certain areas we might want to continue to support because we know those are challenges. Um, there are other things like we haven't had the youth SUD services, uh, in DC have been weak in a lot of ways. Particularly we don't have a residential, um like a level 3.5 residential SUD facility in DC for youth. Traditionally we've had to send our youth out of the district. We are supporting we are funding an organization to start one here now. They haven't quite opened yet. But that is one of the goals, to start one here now. So that's what we look at. These are the gaps. Like, okay, we don't have this, then we try to put those things in. But the goal is not to use opioid abatement to solely fund them. It's to help them get started, and then we look towards other sources of funding, and of course, Medicaid and other areas to continue their funding going forward.
Okay, makes sense. So thank you for that. So Derek, I'll let you ask the next question of Mr. Lane.
Yeah. Carrying on with this notion of addressing challenges and gaps, with opioid settlement funding. Have you all thought about, and how are you building a sustainable behavioral health workforce pipeline in your state or your jurisdiction? So,
Yeah,
Kirk?
so like I said, coming from the state, we knew that the state had a very strong peer support, similar to what Dr. Barker was talking about, peer support network. So, but what they lacked was having peer support involved in different, or buy-in for peer support in different modalities, whether it be partnering with hospitals, partnering with EMS, partnering with law enforcement, partnering in different type of programs and treatment centers. So we looked at that and we were able to expand that ability by in the proposal thing where people want peers to work in their programs and they were going to be supportive of the peers. Then we were able to fund those positions for a limited period of time, plus looking at their sustainability and how they would keep those positions as they move forward. Some of our programs we funded failed. And so it's been a learning deal as we move into our first and second year. But some of them are succeeding. We're seeing the buy-in. They're finding ways to not be dependent on state or federal funds. They're finding ways to fund those programs. I like in some of our overdose response teams where we pair a peer recovery specialist with a law enforcement investigator that responds to these programs. A lot of agencies have seen the success in that. They find the success in that. And because of attrition and trying to hire within their own group, they convert those positions to hiring a peer or hiring a specialized investigator to work an overdose investigation to hold somebody responsible for poisoning that person. So we're seeing and then we evaluate the data that comes out of that. And going back to that overdose response team, a lot of times we're seeing 2 or 3, 4 or 5 arrests where we're seeing hundreds of people being led to treatment and recovery from the peer side of that pairing. But I think the most important thing of that thing is seeing the breakdown in stigma within the agency itself, and then also going out into the community in that aspect with that program. So it's been a win-win when we evaluate those programs. But then honestly, we've had some programs that have just failed. They got into it thinking that this would be a year-to-year funding, never really had the intention of sustaining it, never really wanted to evaluate the information. They just wanted the money. And so we find those things out, and so we kind of learn as we go.
So, Kirk, I want to follow up, and you mentioned folks moving away from abatement funding. I know you guys are only a year in, and Orlando, I'll let you answer this question afterwards. What have been some of the most innovative strategies around sustainability you've seen to date, or things that you're thinking about or providing folks kind of guidance on other creative or innovative ways to sustain the work beyond this initial funding?
So I think for us, I don't know if it's innovative, but I think it's just having buy-in, and finding a way that they see the pluses more than they did the minuses. And they find a way to fund that program for it, whether it be attrition through current staff or going to their city council or to their government saying, look, we got to keep this program, and this is where we're at. So we see a lot of people say, hey, I'm going to apply for funding, I'm going to apply for federal funding. And, with the temperature where it is now, it's really not a good sustainability plan. We've done a lot with recovery housing because in our state, 75% of the funding through SOR and other and block grants go to treatment and very little go to housing. So we've invested pretty heavily in faith-based housing. We're seeing a win-win and looking at the numbers that have been able to increase. We're listening to those communities of the value of that and the buy-in of those communities of breaking the stigma, because sometimes you'll fund a house in a neighborhood and it was all fine and dandy, but not my neighborhood. So we're seeing that community start to change, and listening to that, we expect those problems on the front end. But I think innovative to us is we're seeing the buy-in of the community afterwards and saying, hey, this is a good program and we like these people in our community. We support these people in our community, um, even though they've been there the whole time.
Orlando, any innovative strategies that have been used to date that folks are thinking about how they sustain this work beyond? So if you can take one example where folks have come up with a way to keep going on, even if this funding is not going to be available.
Yeah. Well, first and foremost, let me say that we're funding the birth of what we're funding is very expansive. Like there's a lot of different things. So from like community-based organizations, like faith-based organizations and government agencies, like it goes across the spectrum. I wanted to start off there because you said one of the more innovative things made me think about our faith-based institutions that we're funding, and they have, the biggest thing is train the trainer. So they receive a lot of funding for trainer models. So it allows them to buy all this, all the training that they need from professionals. They're able to get materials and stuff and things of that nature, and they can reuse them. And so now in a lot of cases, they're providing, once they get that training, um, they're able to do a lot of, they don't need to be paid to get the training anymore because they've trained a significant amount of people in their churches to be able to provide the same sort of, evidence-based, experiences. I would say the one example that I'm thinking of right now is the cafe model. It's a model of, engaging people in the community, talk to them about various issues. In this case, of course, opioid use disorder and some of the things that are surrounded with it. So they've trained, we've had churches train themselves and train people at the church in this who are able to now train other people to do this. And so now it becomes a situation where they're training other community, any other individuals in the community to provide the same activity. Um, and then as far as like some of the funding, some of the funding sometimes may pay for, and when they do these cafe sessions, may pay somewhat for food so they can, just snacks or what have you. but these are churches where they have donations, so they can pay for, they can get donations to pay for some of these things themselves. So really, they just need to have the expertise to be able to do these sessions. So I think that's one of the ways you see um across the board. I mean, I use that example, the cafe model, but the train the trainer. If you basically you give people the training, the expertise, you pay for that, then they can actually provide that service to other people without, you having to exert more funding.
Yeah, sustaining that actual service makes sense. So
Right.
that's a great example. I'm looking at the time. So Derek, I think we have some wrap-up question for our speakers. So I'll let
Yeah.
you kind of frame that up, and as we wrap up today's session.
All right, sure. Thank you, Philip. And gentlemen, again, we appreciate your time and responses here. But if we could ask you, knowing what you know now, what might you do differently in terms of moving the work forward or sustaining that work in 30 seconds? If you could answer that question, that would be helpful. Kirk, we'll let you go first.
I was hoping that you would start with Dr. Barker, but that's fine. I think learning what we learned forward is I think we all came into this, and it was hard to come into this, and I'm not trying to speak for everybody else, with just Exhibit E as a guide. There was no template to tell you what right or wrong. You kind of learned into it. So being patient with the process and getting a good understanding of what our needs were and getting it out the door. I think the biggest thing is the realization of the partnerships that you develop and then maximizing those partnerships, getting them all to work together for one common purpose and a direction in the mission.
Makes sense. Thank you. Orlando.
Really 2 words: slow down.
Okay.
If I had a little clicker here, I'd play a little sample of Brand Nubian, slow down. But no, I think there is a rush to spend this money. I found, and I don't know if this is everywhere, but particularly I think from a political standpoint, people are like, we want to show we're doing something, we want to show we're getting the money out to the community. And while it's good in one sense, I think at some point, once the money gets out, you need to slow down a little bit and, like you said, evaluate and observe what's working, what's not working, to be able to assess, like, is there somewhere else we can inject the money? Because, I think overall, I think in terms of sustainability, injecting it in the infrastructure, things that last, things that, you can put the money in, you're going to see it last for a long time. And I'm not only talking about buildings, but I am talking about buildings. But, you know, infrastructure, things that it could be, whether it's data infrastructure, like you're talking about hardware, et cetera, but what have you. But basically slow down, look at where the money's going that you're spending so far, and what, how is it working and how you can improve it, and then move from there.
Right. Slow down and think carefully and critically about how to sustain these efforts. Well, gentlemen, we really appreciate you both. Thank you. You've shared with us your experience. There are definitely some challenges, but I think some real opportunities here that folks can learn from and apply in their own communities. So I'll turn it back over to Dana to close out this webinar.
Thanks again.
Thank you. Thank you, Dr. Brown and Dr. Graham, for that wonderful panel. And also want to thank Dr. Barker and Mr. Lane for joining us today to share their experiences. Love some of what you shared around the need for holistic approaches, the value of evaluation, and love the last thing you said, Dr. Barker, around slowing down, right? And the reference to the brand Nubians. So thank you for that as well. Want to express deep thanks to our RTI team, Barrett, Feeker, again, Dr. Brown, Dr. Graham, for what they've shared today. On today's webinar, I want to reference everyone to online resource hub that we developed, Prevention Institute developed in partnership with Big Cities Health Coalition on last year. I am dropping that link in the chat right now. There are a lot of great questions in the chat and in the Q&A that the RTI team and that we have also tried to respond to. We hope we got to all your questions and provided answers. Additional resources are available through this resource hub. There are a ton of great things there. There is no easy solution. It has to be multifaceted, multi-sector solutions to addressing opioid use disorder in communities. We hope you are engaging many partners in your opioid remediation responses. And so take a look at this resource hub. There's a lot there that could support you and your collaboratives and coalitions in your efforts. Lastly, please save the date for our final webinar in our series this year, which will be held on June 24th from 3 to 4:30 p.m. Our colleagues at ChangeLab Solutions will be joining us and helping us to think more deeply about partnership capacities of multi-sector agencies to support evidence-based and collaborative opioid settlement funding and decision-making. That is so critical to sustainability of the efforts you are putting in place with your funding. And a registration link will be sent out to you and to all who joined either of our previous webinars. Before you exit today's session, we would appreciate your feedback through a short poll that my colleague Claudia will be launching shortly. We really want to hear how you're seeing our efforts to share what you learned today about sustainability, what was most valuable, in addition to what else you'd like to know more about. So please take a few seconds, if you're still on, to respond to that poll. Feel free to reach out to our team at Prevention Institute, Big Cities Health Coalition, RTI, and our guest panelists with any additional questions or feedback that you may have at any time. We are looking forward to engaging and continuing to interact with you to learn more about your work and to answer any questions that you may have. This slide shares how you can reach out to any of us, and we look forward to hearing from you. Thank you for joining today's webinar. Please keep responding to the poll. The more we hear and learn, the better we get at responding to and building capacity around these issues. Thank you.
Take care, everyone.
Thank you all.
Thank you.
Did Mr. Lane know he's still on?
Looks like we got a few folks.
I think we can release you, Mr. Lane,
Okay.
if you have other things to do today. But we really appreciate you being here. Thank you. It was
Absolutely
very insightful.
Yeah, there was a question. There was one more question for you that someone was asking about. What was the question?
Faith-based. I think they wanted to
Yeah, faith-based housing. So we'll if there's any information or links or anything about it, if you could share that, and then we'll make sure it goes out to everyone when we send out the materials.
Yeah.
So Dr. Graham, I posted on the chats on there a link to our website where they can
Okay.
find all that information on there.
Great.
Okay, cool. Sounds good. We'll plot that in.
Yeah.
Awesome. Thank you, guys.
Good. Thanks
Thank
again.
you. Take good care.
Thank you.
Claudia, looks like there are 20 folks on. I can't tell if they're responding to the chat or just hanging out.
There's still a few. Yeah, there's still a few. So just giving, there's still a few answering. So, but I'll give it another minute before I end the poll. So.
Good reviews, good responses. I think The topic of sustainability is one of those that, yeah, folks are constantly thinking about. It's not easy.
Yeah, well, and given the current climate landscape,
Landscape.
Exactly.
more relevant, right?
Very much relevant. Thank you to Barrett for bringing